Good morning. We're about to start. Raise your hand if you're able to hear me clearly. That's good enough. This morning we'll be looking at chapter 12, Shock, which is the third and final core chapter within the EMT textbook. Just like airway management and patient assessment, it is a module. So it's a chapter, but it's also a module. The shock chapter is not as long as the airway and patient assessment chapters. However, it's a chapter that focuses heavily on pathophysiology. So the chapter focuses more on patient presentation. And that's the key to really grasping this particular chapter. So shock, which is hypoperfusion or low perfusion, describes a state of collapse and failure of the cardiovascular system. In order to fully understand that concept, we must understand what is perfusion. So you need to know what is perfusion before you can look at shock. And perfusion is the exchange of oxygen and nutrients and the removal of waste and carbon dioxide from the cells within the body so that they can carry out their normal metabolic function. Shock is the reverse of that. So shock is the inability of the cells to pick up nutrients and oxygen and remove waste and carbon dioxide from the cells, which interferes with their ability to metabolize. Now, there are numerous things that can cause shock within the body. Regardless of the cause, the outcome will be cardiovascular system collapse. So if the shock is not reversed, regardless of the cause, eventually the cardiovascular system is going to fail. In the early stages, the body is able to maintain homeostasis, which is a state of balance. As shock progresses, the blood circulation slows and eventually ceases or stops. The main objective of the body when it is in a state of shock or hypoperfusion is to keep blood flow going to the core organs of the body. And core organs would be brain, lungs, heart, kidneys. These are the core organs of the body. Shock can occur because of a medical condition, or it can be as a result of a traumatic event. Heart attack can lead to shock. Severe allergic reaction, which is anaphylaxis, can cause a specific type of shock. Motor vehicle crashes, gunshot wound. EMTs respond to different types of emergencies to provide care and transportation. They must be constantly alert to the signs and symptoms of shock. So you must be able to recognize the signs and symptoms of shock, and you must be able to determine what type of shock is present. So it's not just identifying the signs, you should be able to determine what type of shock is this, or what type of shock are you suspecting that is occurring for your patient. Pathophysiology. Perfusion is the circulation of an adequate amount of blood to meet the cell's current needs. The body is perfused via the circulatory system. Organs, tissues, and cells must have adequate oxygenation or they may die. In cases of poor perfusion or shock, the transportation of carbon dioxide out of the tissues is impaired. It results in dangerous buildup of waste products, which may cause cellular damage. Shock refers to a state of collapse and failure of the cardiovascular system that leads to inadequate circulation. Shock is an unseen live threat caused by medical disorder or traumatic injury. If the conditions causing shock are not promptly addressed, then death may soon occur. Now, the cardiovascular system consists of three important components, and these three components form what we refer to as the perfusion triangle. So the cardiovascular system consists of the pump, which is the heart, a set of pipes, which is the blood vessels or arteries, and the contents, which is the blood or plasma. These three components, working in conjunction with the respiratory system, will allow us to have good perfusion. So these three components form the perfusion triangle. Any one of these components can have complications, and depending on which component is affected, it will determine the type of shock that the patient goes into. So you have shocks that can affect the pump directly or indirectly. You have shocks that can affect the blood vessels specifically. And you have shocks that can be as a result of blood loss or plasma loss. So it affects the blood or contents specifically. Now, gonna do a review of the circulation of blood through the circulatory system. At this stage in the course, I would expect persons to be comfortable with that. So these three parts can be referred to as the perfusion triangle, mentioned that previously. When a patient is in shock, it can be one component or a combination of the components that are being affected. Go ahead, Mrs. Morgan. Do you have a question?
Sorry, sir, accident.
Okay. Now, the blood pressure is the pressure of blood within the vessels at any moment in time. The systolic is the peak arterial pressure. Diastolic is the pressure in the arteries, while the heart rests between heartbeats. A easier way of interpreting this is the systolic is when the ventricles contract. The diastolic is when the ventricles relax. That's a more an easier way to process the information. So the systolic pressure is obtained when the ventricles contract. The diastolic is when the ventricles relax. Now, apart from obtaining a blood pressure, you will need to be familiar with the pulse pressure, because the pulse pressure is important to your shock patients. The pulse pressure is not the same as a pulse rate. The pulse rate is when we count the pulsation for 15, 30 seconds or a minute, depending on whether it's irregular or not. And we determine the beat per minute. The pulse pressure is the difference between the systolic and diastolic pressure, and it represents the force of contraction. So it's an indication of how strong the heart is contracting. The normal range for the pulse pressure is 40 to 60 millimeters of mercury. If the pulse pressure is below 40, then the strength of cardiac contraction is very weak. And if the heart muscle is weak, it does not stretch very well. If it doesn't stretch very well, it cannot fill with enough blood to push that blood to the peripheral areas and the core organs within the body. So the output is going to be low. If a pulse pressure is less than 25 millimeters of mercury, then it's almost guaranteed that this patient is in shock. Now, a pulse pressure that is above 60 means that the heart is working too hard to push out blood. So the contractions are too excessive, and that can cause blood vessels to rupture. So a pulse pressure that is too high can put the patient at risk for stroke. Specifically, can be a hemorrhagic stroke. Blood flow through the capillary beds is regulated by the capillary sphincters, and these are muscles that control the diameter of the blood vessels. And we went through this when we covered circulation, that the blood pressure within the body fluctuates based on the activities that we are carrying out, and the blood vessels will constrict or dilate depending on the activity. The constriction and dilation of these blood vessels is controlled by the capillary sphincters, and it can be directly stimulated by the autonomic nervous system. It can be stimulated from heat or cold, or the need for oxygen and waste removal. Perfusion requires more than just having a working cardiovascular system. So even though the perfusion triangle consists of the heart, the blood vessels, and the contents, which is the blood and plasma, the lungs plays an important part in the perfusion process. So the three components of the perfusion triangle must be working properly, and the lungs must be able to bring in oxygen. So oxygen is necessary. So adequate oxygen exchange in the lungs is important. Adequate nutrients in the form of glucose in the blood is essential. Adequate waste removal, primarily through the lungs, must occur. So we must be able to get rid of that carbon dioxide. Mechanisms are in place to help support the respiratory and the cardiovascular systems when the need for perfusion of vital organs is increased. So the body has a compensating mechanism. When the blood pressure drops or is not sufficient to supply the core organs of the body will activate the autonomic nervous system, specifically the sympathetic nervous system, which we covered this before. And the sympathetic nervous system is going to produce norepinephrine or noradrenaline, which causes vasoconstriction. So when the blood pressure falls, the blood vessels constrict to increase pressure inside the blood vessels. So norepinephrine, noradrenaline will affect the blood vessels, the alpha receptors in the blood vessels. Then the body will push out epinephrine and adrenaline to sustain the effects. And the epinephrine or adrenaline will act directly on the heart, beta 1 receptors, and the lungs, beta 2 receptors. We have one heart, two lungs. When the epinephrine and adrenaline stimulates the heart muscle, it increases all the functions of the heart. And when it stimulates the lungs or ear passage, it causes the ear passage to open up so that more oxygen can enter the body. So hormones are triggered when the body senses pressure falling. This will cause an increase in heart rate, strength of cardiac contractions, and peripheral vasoconstrictions. And basically what the body is doing is it's constricting the blood vessels that are feeding the peripheral areas and then dilating the blood vessels that are feeding the core organs of the body. So it's redirecting blood flow to the core of the body. And this is what is going to give us the signs and symptoms of shock. So the pulse is going to become tachycardic, and tachycardia is a pulse rate that is over 100. Bradycardia is a pulse rate that is below 60. So the pulse rate is going to become tachycardic because blood is being redirected from the peripheral area of the skin. The skin color is going to change. So the skin is going to become pale, and eventually you might see cyanosis if the blood is not properly oxygenated. Because blood is being redirected away from the peripheral areas, blood carries heat. So the temperature of the peripheral areas is going to change. Because the lung passage is being opened up to bring more air in, the respiratory rate is going to go up. So in other words, the point I'm trying to make here is, if I understand the pathophysiology of what is happening, then I don't need to SWOT the signs and symptoms of shock. I know what to look for. Together, these actions are designed to maintain pressure in the system and sustain perfusion of all vital organs. That is the goal. Keep the brain, lungs, heart, and kidneys perfused. It is this response that causes all the signs and symptoms of shock. All right, now causes of shock. Shock can result from bleeding, respiratory failure, acute allergic reactions, and overwhelming infection. Damage occurs because of insufficient perfusion of organs and tissues. Now, when you're going to study shock, you need to categorize the shocks. So you have shocks that affect the heart indirectly and directly. So that means the heart, it's as a result of pump issues. You have shocks that affect the blood volume. That's hypovolemic shock, right? And it's going to be either blood loss or plasma loss. And then you have shocks that affect the distribution of blood, distributive shock. That's poor vessel function. So you will have to categorize the different types of shocks when you're studying this chapter. All right, now the types of shock. You have pump failure, which can be cardiogenic or obstructive. So pump failure or issues with the heart can be as a result of direct damage to the heart muscle, or it can be because something is obstructing the movement of the heart muscle, whether it's a tension pneumothorax, cardiac tamponade, or pulmonary embolism. With distributive shock or poor vessel function, the issue there is the blood vessels are too dilated. So there is too much dilation of the blood vessel occurring. And there are numerous things that can cause the blood vessels to dilate completely. And that will give us the 4 types of distributive shock. With low fluid volume, it's either from blood loss, which is hemorrhagic shock, or it's either from plasma loss from severe burns, severe diarrhea, or severe vomiting. And whether it's blood or plasma loss, it is referred to as hypovolemic shock. If it is blood loss, it's hemorrhagic shock. If it's not, it's non-hemorrhagic. Now let's look at cardiogenic shock. And I'm gonna have to do a little drawing here. So let me get some lines. So this is, don't want to use blue, want to use black. So let me draw the blood vessel. One line here, one down here. And then let's put some fat inside that blood vessel. Oh, don't want any lines, pencil. So this is a blood vessel, and we have, and specifically, this is the coronary artery. So we have the coronary artery, okay? And there is fatty deposit or bad cholesterol building up in the coronary artery. When it is fat, it is referred to as what? Does anybody know the answer to that question? So if it's fat building up, what is that called? Go ahead, Mrs. Morgan.
Atherosclerosis.
That's correct. So it's ATH, atherosclerosis, right? Now, as you can see, the buildup inside of the coronary artery narrows the diameter of the blood vessel. That means the pressure inside this blood vessel is going to increase over time. And it's not exclusive to the coronary vessel. It could be happening in other blood vessels within the body. So the patient is going to develop high blood pressure over time. If the fatty deposit doesn't break down, eventually it will harden. So eventually it's gonna harden over time. So it starts to harden up or calcify, right? Harden up over time. When it starts to harden, what is that referred to as? Anybody know the answer to that question? So ATH is the fat deposit. When it starts to harden, what is that called? Go ahead, Mr. Card.
Arteriosclerosis, if a pronunciation properly.
All right, that's close enough. So it's arteriosclerosis. ART is the hardening, right? Arteriosclerosis. Now, when it starts to harden, what can happen is the pressure can rip piece of this plaque off, and then it blocks the blood vessel, right? So the plaque is ripped off from the pressure and then obstructs the blood vessel. When it obstructs the coronary vessel, so when it is completely blocked, that's when a patient gets a heart attack. So that's the pathophysiology. Right? The patient now has a heart attack. When a patient has a heart attack, there are three things. So if you suspect that a patient is having a myocardial infarction or a heart attack, you need to anticipate three things occurring in the field with this patient. One, when a patient gets a heart attack, within the first 2 hours, so within 2 hours, this patient can go into cardiopulmonary arrest. So you need to anticipate cardiopulmonary arrest. It can occur within 2 hours. So that's one. And if the patient is in cardiopulmonary arrest, the patient will require CPR and the use of an automated external defibrillator. And as soon as ALS is available, they're going to need advanced cardiac life support. So that's one. Two, the patient can develop congestive heart failure, which can either be dominant on the right side or it can be dominant on the left side. If they have congestive heart failure and it's dominant on the right side, the neck veins will become distended, the liver is going to enlarge, and they start to collect fluid in their lower extremities. So they develop pedal edema. If the heart failure is dominant on the left side, then they will develop fluid in their lungs. So there will be a back pressure created in the lungs, which causes pulmonary edema. So that's the second thing to anticipate. One, cardiopulmonary arrest. Two, congestive heart failure that can be right side dominant or left side dominant. And three would be cardiogenic shock. Now, what cardiogenic shock is, the heart muscle is so damaged that it loses 40% of its cardiac output. So the muscle is so badly damaged that it cannot stretch effectively. If it cannot stretch effectively, it cannot fill properly with blood. If it's not filling up properly, it cannot push the blood to the peripheral areas and the core organs of the body. So a decision has to be made. What is more important? Keeping blood flow to the core. So the body is going to try to redirect blood flow from the peripheral areas to the core organs. And that is what cardiogenic shock is. Quick and fast, it's a patient with a heart attack with a low blood pressure. Your blood pressure is going to be low. Once they have a heart attack, blood pressure is low, you're looking at cardiogenic shock. So cardiogenic shock caused by inadequate function of the heart. A major effect is the backup of blood into the lungs. That would be congestive heart failure, dominant on the left side. Resulting buildup of pulmonary fluid is called pulmonary edema. Edema is the presence of abnormally large amounts of fluid between the cells in the body tissues, causing swelling. Now, if a patient is experiencing pulmonary edema from a cardiac event, can I give, and this patient requires oxygen, will that oxygen be able to diffuse into the blood? That is our question. Will the oxygen be able to pass from the alveoli filled with fluid into the blood? Anybody have an answer? Come on, it's not a complicated question. You have a patient with a cardiac event, they're having pulmonary edema, they require oxygen. Can the oxygen move through the fluid into the blood? No, it cannot. So that fluid is going to interfere with the process of respiration. Now, which equipment, let's see if you guys were paying attention to the airway lecture, which equipment would be appropriate to administer oxygen to this patient? So there's a device that we can use to give this patient oxygen that is going to push that fluid out of the alveoli. Does anybody know the answer to that question? Go ahead, Ms. Kerr.
Sir, I think the non-rebreather mask.
Non-rebreather won't work, so that won't be the device. Who was the other person? There was someone else that had their hand up. Who was that? All right, so Mr. Johnson, you're just grabbing at straws. I don't see how AED come into the equation here. The patient is not in cardiopulmonary arrest. Why are you telling me about a AED? The patient has fluid in their alveoli. They are not breathing properly. We need to give them oxygen. The oxygen must be able to diffuse into the blood, but we need to push the fluid out of the alveoli. What device can do that? Good. Thank you, Ms. Linton. A CPAP device. So it's either CPAP if they are communicating with you, it's CPAP. They are not communicating, it's going to be positive pressure with your BVM or pocket mask. That's what is going to push that fluid out. Okay. Edema is the presence of abnormally large amounts of fluid between the cells in the body tissues causing swelling. Pulmonary edema leads to impaired respiration, which may be manifested by an increased respiratory rate and abnormal lung sounds. So this patient will present with crackles when you listen to the lungs. Sometimes it is so bad that you don't need to listen to hear the crackles. You can hear it when they speak. And sometimes they will cough up the sputum with a pinkish color. Cardiogenic shock develops when the heart cannot maintain sufficient output to meet the demands of the body. All right, now obstructive shock. So we have looked at direct damage to the heart, which is cardiogenic shock, and we looked at how the patient get to that point as it relates to having a heart attack. Now let's look at conditions that can affect the heart indirectly. So we're going to look at conditions that can affect the heart indirectly. So there are three conditions that you need to be familiar with that can affect the movement of the heart. So the heart is not damaged, but something is affecting the ability of the heart to move and stretch properly. Now, the first condition is a cardiac tamponade. Now, the heart muscle has a membrane around it. So let me exaggerate that membrane. All right, so the heart muscle has a membrane around it. It's referred to as a pericardial sac. The membrane can be torn or ruptured. Right? It can be torn or ruptured. And it has an inner lining and an outer lining. So you have a visceral portion to the membrane and a parietal portion. If it is torn or ruptured, what can happen is blood can start to fill the sac. So blood start to fill this sac. Right? Now, when it fills the sac, the heart muscle ability to move is impaired. So as it fills that sac, the space becomes very limited for the heart to stretch. And if the heart cannot stretch, it cannot fill properly. And if it cannot fill properly, it cannot pump blood effectively to the peripheral areas of the body and the core organs of the body. So the body has to make a decision, redirect blood flow from the peripheral areas to the core organs. This inability to move will cause the cardiac output to drop. So the blood is eventually going to fall. And this results in obstructive shock. So a cardiac tamponade can cause obstructive shock. And that's what a cardiac tamponade is. It is blood or fluid collecting in the pericardial sac that interferes with the movement of the heart, leading to a reduced cardiac output. So that's cardiac tamponade. Now, attention pneumothorax. Attention pneumothorax. So this is your lungs. Right, this is the lungs. Come up here. Right, and the lungs, just like the heart, has a membrane. Right, so there is an inner lining So that membrane and an outer lining, it's the pleural membrane. Now, what can happen is the membrane can also rupture, just like the one around the heart can rupture, right? And it's common in blunt force trauma. It can occur with penetrating trauma, but it's very common with blunt force, what we call a paper bag effect. So the person is involved in a motor vehicle accident, and before the point of impact, they hold their breath. So air is inside the lungs. The inner portion of the vehicle collapses on the chest, and it causes a paper bag effect, and the lining of the lungs ruptures. When that lining ruptures in the membrane, air will start to take the path of least resistance. So if that opening is larger than the air passage, when the patient breathes in, instead of the air going into the air passage, it's going to go into the pleural membrane, and then it will cause the lungs to collapse. So it's going to cause the lungs to collapse. This is what we call a pneumothorax. So a pneumothorax is air collecting in the pleural space that causes the lungs to collapse. Now, the issue is in the mediastinum, we have the heart and the major blood vessels. If air continues to accumulate in the pleural space, the pleural lining will expand. So it's going to expand like this. So it starts to expand. Right? It starts to expand in the mediastinum. So when the pleural lining starts to expand, it's going to eventually create pressure on the heart. So as it expands, the heart no longer has the room to stretch and fill with blood effectively. So the cardiac output is going to be reduced. And once the cardiac output is reduced, the pressure will not be sufficient. Because the pressure is not sufficient, the patient will start to go into shock, and this is obstructive shock because the heart is being obstructed. So this is what we call a tension. So a tension pneumothorax means that the air that is accumulating in the pleural space is creating pressure or tension on the heart. It's not the same as a spontaneous pneumothorax. It's not the same as a open pneumothorax. For it to be called a tension, it means that the membrane is creating tension on the heart. That is why it is referred to as a type of obstructive shock. So that's a tension pneumothorax. All right. Now, the third condition that can lead to obstructive shock is a pulmonary embolism. Now, the term embolus and thrombus refers to clots. So embolus and thrombus refers to clots. The difference is an embolus is a clot that travels. Right? So an embolus is a clot that travels. Thrombus is a clot that forms within a specific area of the body. So it forms there. It didn't travel there, it formed there. Now, what can happen is a patient can have deep vein thrombosis. So a patient can have a condition in which they have clots in their veins, in their legs. So that's deep vein thrombosis. Now, what can happen is one day, because of whatever activity, the clot is dislodged. So it becomes dislodged. When it becomes dislodged, it starts to travel via the venous system. Once it starts to travel, it is now an embolus. It is in the venous system, so it's going to travel to the right side of the heart. It's going to enter the inferior vena cava and empty into the right atrium. Then it will pass through the valves into the right ventricle, and then it will go up into the pulmonary arteries. When it enters the pulmonary artery, it will either do one of two things. So let me draw the pulmonary artery. So let's say this is a pulmonary artery where it bifurcates. Let's say this is a pulmonary artery. What can happen is the clot can lodge right here, right in the middle. If it lodges in the middle where the pulmonary artery bifurcates, that's going to cause a saddle embolus, and the patient will immediately go into cardiac arrest because there's no blood flow there. That's a complete block. Now, the other thing that can happen is, let me erase this, go back to pencil. What can happen is the clot that is traveling can block one side. So it blocks one side. So that's a pulmonary embolism. The patient now has a pulmonary embolism. So it's a clot that travels from the venous system and blocks the pulmonary artery. That's what a pulmonary embolism is. Now, if it blocks one side of the pulmonary artery, it means that there will be a decrease in the amount of blood that is going to the lungs. If there is a decrease in the amount of blood that is going to the lungs, it means less blood will be coming from the lungs to the heart. As a result, if less blood is coming from the lungs to the heart, it means less blood will be pumped out of the heart. And the cardiac output will eventually be compromised. Once the cardiac output is compromised, the patient is now in obstructive shock because this clot is indirectly affecting the pumping action of the heart. So these are the three most common conditions that can cause obstructive shock. And obstructive shock means that the heart muscle is fine, but something is indirectly affecting the movement of the heart muscle. And in so doing, will ultimately affect cardiac output. So the cardiac tamponade, this is a collection of fluid between the pericardial sac and the myocardium. If it is a small amount of fluid, it is referred to as a pericardial effusion. It's a large amount of fluid, it is referred to as a cardiac tamponade. The fluid collection can become large enough to prevent the ventricles from filling with blood. It can be caused by blunt or penetrating trauma, And the signs and symptoms, the key signs and symptoms are referred to as Beck's triad. So what you're looking for a patient with a history of blunt or penetrating trauma or an infection of the pericardial lining or membrane. This patient will present with distended neck veins. So a back pressure will be created when the heart is not able to stretch. They are going to get back pressure in their neck veins. So the neck veins will be distended. Because there is fluid or blood collecting over the heart sounds will be muffled. So the patient is going to have muffled heart sounds. And because the cardiac output is compromised, the systolic pressure is going to drop and it's going to appear as if the diastolic is going up. So the blood pressure is going to be low. So these are three key findings for a cardiac tamponade: distended neck vein, muffled heart sounds, and narrowing of the pulse pressure. So the blood pressure is going to be low and the pulse pressure gets narrow. Tension pneumothorax caused by damage to lung tissue. The air normally held within the lung escapes into the chest cavity. The lung collapses and air starts to apply pressure to the organs inside, including the heart and great vessels. Once the air starts to create pressure on the heart, we now have a tension pneumothorax. This is a life-threatening emergency. Pulmonary embolism. Well, let me back up a bit. It's common, very common with blunt force trauma to the chest. It can occur with a sucking chest wound, but not something that's common because there's an opening to the chest, so air can escape. But with the blunt force trauma, there's no way for that air to be released unless ALS providers or the doctors at the hospital create a opening. So paramedics would do needle decompression to release that pressure in the field, and that doesn't fix the problem, it just buys time. Eventually the patient will need a chest tube. That is what is going to reinflate the lungs over time. The needle decompression that is performed by the paramedics is just to relieve the ear pressure to cause the heart, relieve the pressure of the heart so that it can effectively stretch and pump blood out. So we're buying time. And a needle decompression is basically you're using a 14 gauge IV catheter and it's being inserted in the chest at a specific spot within the chest. The needle doesn't remain in the chest, the catheter does. And that will release the ear pressure. So if you're in a first world system and you recognize that your patient is developing a tension, then you need to request ALS as soon as possible. If you're not in a first world response or proper EMS response system, you're going to need to get that patient to the hospital as quickly as possible. Now, what is important for you in the Jamaican setting is any patient that you have with blunt force trauma to the chest or abdomen, listen to their lungs early. So early detection is the key to this patient's survival. So you're looking for a patient with blunt force trauma to the chest. For your medical patient, you're looking for a patient who had chronic respiratory problems and suddenly had a coughing episode and then started to have trouble breathing. This patient is going to have distended neck veins as well. The affected side is going to have diminished lung sounds. So there will be diminished lung sounds. The pressure is going to drop. Pulse is going to go up. They're going to have increased significant difficulty breathing, right? They're going to become hypoxic. Some can become combative if that pressure is not released. A late finding for attention is going to be a trachea that's shifting. So the trachea starts to shift away from the side that is collapsing, and that is a late sign. So if you find a patient with a trachea that's shifting, within less than 10 minutes, that patient is going to go into cardiac arrest. So that's your tension pneumothorax. Pulmonary embolism, a blood clot that blocks the flow of blood through the pulmonary vessels. If massive, it can result in complete backup of blood in the right ventricle. It leads to catastrophic obstructive shock and complete pump failure. And with your pulmonary embolism, there are numerous ways it can occur. Patients with deep vein thrombosis, a patient who has been sedentary for a while, so they're on a long flight or they're driving for a long time and they're not wiggling the toes, and then they stop and move the leg and a clot is dislodged. Females that are on birth control, so there are certain birth controls that can cause clots to form in the blood vessels. So, and a patient that's recovering from surgery, hip surgery, surgery to the lower extremities, they can have clots form in these areas that can result in a pulmonary embolism. It's going to cause sudden difficulty breathing. So it's going to result in sudden difficulty breathing or acute difficulty breathing. The patient will present with cyanosis. So cyanosis is a common presentation for these patients. And what you will observe is that when you give this patient oxygen, the cyanosis doesn't improve much, which that would add up. So if there's a blockage in blood flow, if the blood can't circulate, it doesn't matter how much oxygen you're giving. Right? So the cyanosis is not going to improve much for these patients. So just keep that in mind. That would be obstructive shock. Now, the next type of shock is the distributive shock. We're at 9:27.